So thanks so much for coming out this morning. I'm really excited that I get a chance to talk to you guys about a really important issue. I am the principal investigator from a grant that we received from the state of Michigan to try to educate people out in the community a little bit more about autism, early screening, diagnosis, and referral. So I appreciate you all coming out. Just to get us started, for anybody who's getting CMEs or CEs, this has been approved by Wayne State University, and in order to do that, all of these activities have to be fair, balanced, and free of commercial bias, and also all of the information that you see today will be fully supported by scientific evidence. So I just wanted to inform you that we have been approved to do that. What we're going to do today is we're going to focus on identifying symptoms of autism. We're also going to look at some different screening tools, including the MChat and another screening tool available online for children who are a little bit older. We're going to look at a little bit of information on assessment and talk about the difference between screening and assessment for ASD. Hopefully by the time you guys are done, you'll have a general understanding of what it takes to do that. And then also we're going to talk a little bit about applied behavior analysis, which is an evidence-based treatment for children with autism, and you'll have some background on what that is, and also how to get folks enrolled into that particular type of service. And then we're going to talk a little bit about some of the different roles and responsibilities of people on the treatment team. Autism Spectrum Disorder really is a very complicated disorder, and it takes a lot of different people working together. So we're going to talk a little bit about the roles and responsibilities of all the people involved. Just to get us started, though, I think it's important to talk a little bit about why we're focusing on autism and some of the changes that have taken place in the population. Currently, children with autism, it occurs in about 1 out of 68 of every live births, and that is really about 1% of the population currently. It has grown tremendously in the last few years. We've definitely been on an upward trend for quite some time. If you look at the amount of children who are diagnosed with autism just in 2000, that was occurring at that point 1 in 150 live births, and now we have increased 119% up to 1 in 68 births. And that's really important because we need to make sure that we're catching kids early because it is happening so frequently. We need to make sure that a lot of different people who touch children are available and understand what this is so that we can really focus on early intervention and screening. One of the main reasons why we want to focus on that is because not only does it help the child and the family, but it also is a tremendous cost saving for our government and for the community. It costs quite a bit more to provide services for adults with autism than it does for children with autism. So it's really important that we get going right away and we really focus on catching kids as early as possible. It could cost anywhere from $175 to $196 billion for our country to treat adults with autism, where for children it costs more along the lines of $61 to $66 billion. So that's definitely a huge difference. And with the increase in prevalence, we're looking at over time, if we don't do a lot with early screening, diagnosis, and referral into effective evidence-based treatment, we will at some point have a lot more adults with autism than we do now. So just as the prevalence is growing, we can do a lot for early intervention and treatment. Yes, sir?
Is the prevalence growing, or is it because there's more screening?
So I think it's a combination of those kinds of things. I am not an expert in the difference between, what's happening out in the community and what all the different theories are. There's a lot of things out there, but the evidence does show that there are some changes on both ends. So there are more children who are being screened and diagnosed early, but also there are still more children in the population with autism. But the reason why isn't really something that people have identified a cause for. So there are a lot of researchers, scientists that are looking into causes of autism, but that's not something that I'm really prepared to discuss right now. And there are a lot of people that really just don't have a good solid answer, even though there are a lot of theories. So our goal is, if we can, like I said, identify children early, we can have a cost savings of up to 1/3 of what we may have spent on adults with autism, we can have a cost savings by identifying children and treating them early. And we'll talk a little bit about what those treatments look like as we go forward. So the next thing that I want to do is I really just want to acclimate everybody to what autism is. And we're going to spend a little bit of time talking about the diagnosis and some of the symptoms that you might see if you see children with autism. But just to get us started, autism is a neurobehavioral syndrome. So very closely tied to neurology. A lot of kids with autism also have other neurological issues. So that's one of the areas that we work in a multidisciplinary way, making sure that we're connecting with our medical professionals as well. Symptoms are going to occur within the first 3 years of life, although many parents report that they see the symptoms of autism much earlier, and there are a lot of tools, which we will talk about, that can identify symptoms at a much earlier rate. There are two general categories that we're looking for when we're diagnosing autism, and those are social communication impairments and repetitive and restrictive stereotype behaviors. So I'm going to talk a little bit about what each of those mean. But what I want you to do is really envision basically a triad of autism symptoms. So we're looking at impairments in areas of social interaction, which is one of the primary difficulties that children with autism have. We're also looking at different impairments in communication. And then we're looking at some very specific behavioral impairments that children with autism have that may be different than behavioral impairments that you might see with other developmental disabilities. So that's how we're going to conceptualize that. And we're going to talk a little bit about what each of those areas means. So the first thing we're going to focus on is social skills. So you may know a lot about typical development. I'm hoping that you guys at least all have that reference point. But in typical development, kids are really focused on interacting with their environment in a very seamless way. Children with autism differ pretty considerably in their ability to attend. The things that you might notice early on that parents tend to report could be a lack of eye contact. Many kids are resistant, but not all are resistant to being held. There's not a reciprocal kind of interaction between smiles and tickles and those kinds of things that you may not see. If you do see it, you may not see it at a high enough rate that you would see in typical development. There's a lack of other types of social interaction like joint attention, like pointing, those types of things that you wouldn't see. Kids that are talking, you may be able to speak with them, and I'll talk a little bit about communication in a minute, but their communication skills do not have as much of a social component. So when you say something to them, they may not understand the social reference to it. So for example, many kids they'll interpret language very literally. So if you say, your mom's got eyes in the back of her head, they may not understand that that means that your mom is watching you at all times. They may literally think, oh, what do you mean she has eyes in the back of her head, and then become very confused. And that's not necessarily a communication issue. That's a lack of social skills and perspective taking. So things like rules, things like social behaviors, that can be very difficult for children with autism. The idea of perspective taking is very closely related to theory of mind. Is anybody familiar with the concept of theory of mind? So really understanding that I can think one way and somebody else can think a different way. And that has a lot to do with some of those early deficits. So kids don't attend to the social world. They don't attend to their environment very well. They have a really hard time predicting behavior of other people. And that's really at the heart of what makes autism different than some of these other things. Because they have those issues, that really affects their ability to understand and use facial expressions. It really makes it difficult to have a variety of social interactions. Their play looks very different. Sorry about that. They have a difficult time with groups, so it's difficult for them to manage that or navigate those kinds of situations. And also, other kinds of things may pop out. When they're in these social situations, you may see behavior problems. You may see anxiety. You may see some other kinds of things because they don't have the skills. They don't have the social skills to be able to appropriately interact. So some of these other things that make autism look more apparent out in public can really be related to some of these core skill deficits that they really lack in the social area. So what we're going to do next is I'm going to play a video for you. You're going to observe two children that are playing. one child has autism and the other child does not. You'll notice that it's the younger child that does not have autism. And what I want you to do is, if you have some place to take notes, so you guys have some information packets, if you could, as you're watching the video, maybe jot down a few things looking at the social skills that we just talked about to see if you can recognize some of those things in the child with autism.
What you doing, Jackson? What are you doing, Juliet? Playing with some pegs? Are you playing with some pegs?
So in that video, hopefully you were able to see a few things that you could recognize from the slide before. Did anybody notice the difference between the two children in their, sorry about that, in the eye contact that they were making with the person who was videoing? I think that was their father. Did anybody notice the difference? So Jackson had a much different response to the father's voice. You noticed when Juliet was playing with what she was doing, the father started to talk. He said something, I don't remember what he said, but as soon as he said something, she immediately referenced him. She looked right up, but Jackson didn't look at all any differently than he did as if nobody else was in the room. She had also taken her little block and kind of, showed it to her dad a little bit, like, hey, look at what I have, made some smiles, those kinds of things. So, and she was a much younger child than the other child was as well. So you can really see the difference between development of social skills in that particular video. The boy didn't really make eye contact. He didn't really seem to change his behavior or adjust anything. He didn't try to engage with his sister at all either, which is also something that you would notice from children with autism. So even though they're sitting and doing parallel play, typically kids will somewhat engage with each other, whether it's showing or talking or trying to grab the other person's toy. So there really wasn't any of that as well. So those are some of the things that that you might see as differences between a child with autism and a typically developing child. So hopefully these were some of the things that you wrote down. Poor eye contact, lack of response, lack of initiation, not referencing, not trying to share, not pointing, those kinds of things. So the next area that we're going to focus on is qualitative impairment in communication. So we focused on the social skills aspect, and it's really hard to intertwine some of these things because social and communication really go hand in hand. But when you're thinking about communication, some children with autism are completely nonverbal. So that's very easy to tell. Obviously, they have a lack of communication skills if they don't speak. But some children with autism do speak. And then you have to look at not just the amount of speech that they have, but what is the quality of their speech. And when you think about that, you're looking at things like how rote is it? How big is their vocabulary, and how do they actually use their speech? So those are some of the things that you might notice. A typically developing child is going to have a lot more skills in things like responding. I'm going to come back to this slide. They're going to respond to sounds in the environment. They're going to respond to when people talk to them. They're going to be able to engage in conversations. They're going to be able to engage in communication type activities while they're in play. So you might see a child engaged with some sort of a theme play, and they might be having the characters talk, those types of things. You also have this listener-speaker response, and it's fairly reciprocal. When you're in a conversation, you're going to be able to make sure that you're checking in with the listener, not just talking over them or not just talking about a certain topic. And these are some of the things that we notice with children with autism. So sometimes they have a really good vocabulary, but their vocabulary isn't really flexible. So you might notice a child, sometimes they'll have something what we call echolalia. And echolalia is a repeating of something that's already heard, but it doesn't have a functional communicative intent. So you might hear a child saying something after you say something. So you would say, "Hi, Johnny, how are you today?" And they would say, "Hi, Johnny, how are you today?" So they have the speech, they have the ability to communicate, but when they use those words, it isn't as meaningful as it would be if you were working or talking with a typical child. Some other children also will have similar, what we call scripted behavior with their speech, and you may see kids that watch movies, and then they'll talk out the whole movie. They can act it out. They can even take their toys, and it looks very much like play. It looks very much like theme play, but none of it is novel. None of it is spontaneous. None of it is their own. It's all plucked from somewhere else. So those are some of the differences that you might see just in the communication area. And that's a little bit different than social. Like I said, it kind of overlaps a lot. And the DSM just changed recently. It used to be social and communication were separate, but now they really combine those into one area because it's really difficult to tease some of those pieces out. So just looking at typical development also, by the time a child is 15 months old, they're going to have two-word phrase, or they're going to have at least single words, and by the time they're 24 months old, they're going to have probably two-word phrases. So this is a really key piece. If these things are absent in a young child, that's a red flag for the fact that maybe you need to look at them for autism or some other developmental disability. The echolalia or the parroting or the scripting behavior that I was talking about, that's another big red flag. If kids are just directly repeating what you're saying and they're not initiating conversation, or their conversation seems to be very rote or repetitive, another key thing is sometimes kids will use almost a made-up speech. They'll have words that mean something very specific to them, but they don't mean anything to somebody else, and you almost have to learn their own language. That would be something else that would be present in autism that you wouldn't see in typical behavior. So like I said, it's not just that the kids don't have language, or it's not always that their language is delayed, but it might also be the fact that it's just odd, or it's not used in the same communicative way as it is typically. So we're going to do the same thing. I want you to take a look at this video. Our goal for this video is communication. So I want you to look at the communication skills of this child, and I want you to also evaluate what you see here and if you see any of the things that we were talking about.
Hello? How are you today? What? How's it going? What you doing today? What you doing? Okay, talk to you later. Okay. Hello? Talk to you later. Bye-bye. Goodbye. Hang the phone up.
So what did you notice in this video? Anybody notice anything specific in this video based on what we talked about in the other slides?
Everything that
He repeated everything that she said, exactly. So the language wasn't, he didn't expand. He didn't engage really. It was more of a mimic or a parroting, although it was a very social situation. He was having a good time, she was having a good time. So kids with autism are not necessarily that kid in the corner sitting and rocking. They can be somewhat socially engaged. It's just the quality of that is going to be different than what you would see in a typical child. So he had, I think she said hello, he said hello, which seems very natural, but then when it moved on, it got a little deeper. She said a couple of things, he mimicked them back, or maybe he went back to like the beginning of the script. She was trying to hang up the phone and move on to the next thing, and he went back to hello, hello, not really following the interaction like a typical child would. So those are the things that you might see with a child with autism. And I use this example because I think a lot of people get confused when they do see language that, well, he's talking, he's engaging, he must not have autism, but it's really the quality of those kinds of things that are important. So when thinking about, and this is pretty much what we just went through, his language really didn't have communicative intent, and he couldn't continue the reciprocation piece of the conversation. So the next area that we're really going to focus on is the behavioral section. So kids with autism do have a very specific behavioral deficit, and that has to do with restrictive, repetitive, and stereotyped patterns of behavior, interests, and activity. So sometimes kids with autism will have movements that are odd, and I think most people are familiar with those kinds of things. So you may see things like rocking, you may see spinning, you might see like odd finger movements and poses. Those types of things I think most people are familiar with autism. But sometimes this stuff comes out in a little bit of a different way. So maybe they will only play with a certain type of toy. Maybe they will only watch SpongeBob. Maybe they will only engage in a certain way. You also might notice that their toy play might also be very repetitive. So just like they had, I talked about the scripting, they may play with toys, but it's the same scenario over and over again. They take the truck and they move it in this way, it goes to the top of the ramp, and then they watch it go down. Those are the types of things that you might see with children with autism. They also tend to have a really narrow range of interests. So sometimes with higher functioning kids, they may only talk about certain topics, or they may listen to you for about a half a second if you're talking about something, but then they switch it back to whatever their interest is. So whether it's, you know, what kind of model, make, and color your car is, or, you know, stop signs and planes, or different things like that, they may be very hyper-focused on certain areas. So the kinds of things, like I said, that you might notice in addition to that would be odd responses to stimuli in the environment. So a child with autism, they may have a different response to smell or sight or sound or pain than other kids might have. So some examples of this would be the child who hears the lights. Like if you ever go through the store and you have the fluorescent lights and they kind of buzz, and that's really bothersome to them. Or there was a child that I knew that, you know, he would walk into like a restaurant or Dunkin' Donuts, and the smell of bagels made him nauseous. So he like had to leave and vomit. Other kinds of things that you might notice is kids might be really sensitive to their clothing or to touch or to certain kinds of things. Sometimes you get the complete opposite effect. They seem like they don't even register anything at all. So it's not just oversensitivity to sensory stimuli, but it might be a lack of sensitivity to sensory stimuli and not attending to those things. So sometimes you might see that they kind of have tunnel vision, and like they're looking here, but something that happens, they may not catch something over here that maybe somebody walks into the room or something like that, and they wouldn't notice those kinds of things. And that kind of goes along with also the sensitivity to pain. Some kids with autism, their parents report that they get hurt, and they don't really have any kind of a response. They don't seek comfort, they don't cry, they know that it hurts, they fell down, they got a big egg on their head, but it's not really registering with them to do any of those things. And this stuff is related to two core skills. It's related to attending, which is a huge deficit for kids with autism, and it's also related to social skills. So if you think about pain, we may feel pain, but we may respond to pain differently, right? And mostly when you're seeking comfort from someone, that's a very social kind of engagement. So I would say that it's not that they don't feel these things all the time, but how they attend to them and also how they respond to them are going to be different than what we may do. So we may respond to them differently than we may see from a child with autism. So we're going to watch another video. This is the last video that we're going to watch of this type. And what you're going to be looking for in this video is a behavioral skill deficit. So you're going to be looking for how this child responds behaviorally to the environment that she's in.
Sorry. It's okay. Can I see this one? You gonna get it? Yeah, I'll take a pause while you get it.
So what kinds of things did you see in this video? Anything that was salient to you?
She got upset every time the cup tipped over.
Thank you. So she got upset every time that the cup tipped over. So you might have noticed she had a very specific goal, and the goal was a little odd, right? It wasn't the way that people typically play with cups and saucers and dishes. So typically a girl that age is going to be having a tea party. She's going to be sharing. She's going to be doing those kinds of things. So she had a really different agenda with those toys. But when it didn't work out quite the way that she had hoped, there was also this behavioral response. So you probably noticed the repetitive behavior, right? You probably noticed the odd behavior associated with that. And then also this very specific response. I don't know if anybody picked up on this, but when something didn't go her way, she flipped right into this odd whining behavior. And then when something got fixed, she shut it right back off. So like typically a child, if they're upset, they're upset. They're going to be upset for a second. But it was really two different conditions almost for her. And it was very easy for her to go back and forth, which is kind of an odd social response as well. So that was very different for a child that age. She was probably 4-ish. And you might be able to kind of empathize with the parents also. That has to be extremely frustrating to try to engage with a child and not be able to predict like when she's going to be really upset. So that can be really troublesome to parents and professionals who are working with children. But that's just one example of what you might notice with a child with autism. So now that we kind of have an understanding of some of the things that you might be looking for to try to identify within kids with autism, now we're going to talk a little bit about how do we go about doing that in more of a clinical way. So rather than just kind of eyeballing it, and going, that kid probably has autism based on those kinds of things, there are actually some screening tools that we're going to talk about in order to better make some referrals to get a diagnosis. So the American Academy of Pediatric Pediatricians recommends that we are doing a survey of autism at each developmental visit. So they want you to do both developmental screenings, and they also want you to screen for autism, particularly at the 18-month and the 30 or 24-month, depending on when the kids are coming in. But that's kind of the key time where we're really looking to try to identify kids with autism. Most parents at that point know that there's a problem with their child, or they have some concerns, or some of the things that you're going to observe are going to be pretty apparent, and you are likely to see them even in a short office visit. So that's kind of the goal with that. And we're going to talk a little bit about the MCHAT. And I do want to say that we're going to talk about diagnosis in a few minutes, but the screening tools are very different than the diagnostic procedure. The screeners are really to over-identify, because we want to make sure that we catch everybody, and then a lot of times when they get to the actual diagnostic tools, those kids may be ruled out. But it's important that even if you have a sneaking suspicion based on the scores for the MCHAT or some other type of diagnostic screener, that you are referring them for a diagnosis, because the goal is not that you're telling the parent that the child has this particular disability, but that you're going to talk to professionals that are more experienced in the area of doing diagnosis, so that you can make sure that they do or that they don't. That's really the most important thing. So we're going to talk about the MCHAT as a screening tool. The MCHAT is very easy to use. It's actually available for free online. We'll take a look at it in just a minute. It's a total of 23 yes and no questions. The measure itself focuses on that triad that we talked about. So the questions are reflective of social questions, communication questions, and behavioral questions to try to pull for those types of behaviors that may be happening in the environment. You can use it for kids from 18 months to 4 years of age. It detects ASD. It could also detect other language impairments or mental retardation or cognitive impairment. So kids who score high on this may not end up having autism. They may end up having a speech and language impairment, or they may have an alternative cognitive impairment. As I said, it's a screener tool, so it's overly sensitive. You're going to get a lot more false positives, and then later on, the diagnostic tools are going to then rule those kids out and be more specific in the diagnosis. So if you look at the MCHAT, we're going to look at that in just a second, but if you score on more than 2 critical items or any 3 items that are failed, you're going to pretty much say these kids probably need to go and have a referral. The nice thing about this is I'm just going to show you a few of the questions, but in the same document on the same web page, you can also get information on scoring. They have a lot of other tools. The MCHAT has actually been published in several different languages, and there's a lot of information online about how this has been used. So I'm going to go right now to the MCHAT online so that we can take a look at what some of those questions are. Oh, no, I'm sorry. That's not what I wanted to go to. Also not what I wanted to go to. Okay. Okay. Sorry about this. There it is. Okay, so here's an example of some of the questions. As I said, they're all yes and no questions. So you might read something like, does your child pretend, play, or make believe? So that's going to come from that social area, right, where the child is not really engaging, they're not using their communication during play. Does your child point with one finger and ask for someone or something to get help? So they're going to point as a way to communicate with you, and a lot of kids with autism are not attempting to communicate with you, so that's a big red flag. You might also see on here, is your child interested in other children? So they should be looking at children, they should be approaching children, those kinds of things. Does your child get upset by everyday noises? That would be an example of something that would come from that behavioral repertoire that we talked about. And then there's some other things like just general developmental things. So like, does your child walk? Most children with autism are not going to have significant gross motor impairments. So that would kind of rule out maybe that there's some other type of a problem if the child is not walking. So that's an example. And then let me go back to our PowerPoint. Actually, what I'm going to show you now is a video of somebody administering the MChat in a interview form. So we'll watch just a couple minutes of this.
Say she has a 2-year-old son, Grant, and we're going to do the MChat revised. If you point at something across the room, will Grant look at it and follow your point? How would he respond if you point at something? Would he point to it? Would he look at the object? Would he look and comment on the object? Would he look if you say, look, and point at it? Have you ever wondered if Grant might be deaf?
That was one of the first things that I thought. And I know we can hear
Does Grant pretend or make believe? Like, would he pretend to drink from a cup or answer the telephone? Now I'm just going to give you a list of things, and you just tell me if you would or wouldn't do any of these things. Would he? You said he wouldn't drink from a cup. Would he eat from a toy spoon or fork? Would he pretend to talk on the telephone? No. Would he pretend to feed a doll or a stuffed animal? Would he push a car as if it were going on the road?
not really. No.
Has he ever, oh sorry, no.
He was going up for covers, but as far as keeping it or no.
Okay. Would he ever pretend to be like a robot, an airplane, a ballerina, or any sort of character from TV or anything? Would he put a toy pot on a pretend stove? Would he stir imaginary food? Would he put an action figure or a doll into a car or truck and pretend water?
So I'm going to go ahead and stop it. Obviously, you guys have access to this. It's free. This is online if you want to watch the whole thing or if you want to just read through the screening tool yourself. These are all the questions directly from there. This is being done in an interview fashion. This isn't always the way that the MChat is done. You could do it in an interview fashion. If you did this, you might get some more information, some more description about what they might mean. You might be able to score it more accurately to determine. Sometimes parents will misinterpret the questions and they'll say like, for the question that she was kind of considering with the toy truck, where he did play with cars, but not necessarily in the fashion that they were looking for. So you might see with some of these kids that have scripted behavior, or they may push something in a rote way, and the parents may interpret that as more thematic play. So it's helpful to, if you do something like this, to get a few more questions about, can you give me an example, or what do you mean? That obviously is going to take more time. So that type of an assessment probably wouldn't be done in a doctor's office because you may not have that kind of time in addition to everything else. But in other kinds of settings, like potentially in a school setting or maybe in more of a clinical setting where kids are maybe being evaluated for services or things like that and trying to figure out do they meet the criteria for autism, that might be something where you have the time to do something like that, because then you would have an opportunity to talk a little bit more with the parents about that. But that's just an example of the type of thing that you might see if you were going to do the MChat. Oops. Did I lose my PowerPoint? Shoot, there it is. Okay, so you guys all have a copy of this, so you can look at what those references are. You can go online and see other languages that the MChat has been translated in. FirstSigns.org is a nice reference for people that just are looking for a variety of different resources and tools for this type of thing, so you might want to check that out. And then also our video that we just played is also on there if you guys want to go back and take a look. The next thing that we are going to look at is we're going to look at a screening tool for children who are a little bit older. So this, oops. All right, so this is the Autism Spectrum Screening Questionnaire. So you would use this tool for children who are between ages of 7 and 16. The reason why I put this one on there is because this is also free. There are several other screening tools that are available. Sometimes you have to have a master's degree in psychology or some other kind of criteria to purchase them, and they are fairly expensive. But as a screening tool, if you were just looking for something that's easy to get access to, this is the same kind of thing as the MChat, but it's something that's available for kids who are a little bit older. This is on a 3-point scale, and it ranges from scores of 0 to 54. If you score a 19 or higher, then that would indicate that there might be autism in this child. So same kinds of things, but you might have, on this one, you're going to have a little bit more with language, because at that point, the child's language would probably be more developed. So you might see has a deviant style of communication with formal, fussy, old-fashioned, or robotic-like language. Again, those kind of come from those social skills areas. Idiosyncratic words or expressions. This we didn't talk about, but has a different voice or speech. You might notice that a child with autism has a different tone or a different rhythm than typically. This one is a good one for social. Usually uses language freely but fails to make adjustments for social context. So you might talk one way to your grandmother, and you might talk a very different way to your friends, and kids with autism may not adjust for that. They also don't tend to adjust for distance. So if I'm going to talk and make sure that you guys hear me in the back, I'm going to use a much higher voice, a louder voice, than if I'm talking maybe sitting next to my husband having an intimate dinner at a restaurant. I'm going to use a much lower voice. So their voice may not modulate for distance in social situations. So again, you can read through this and you can see what that is, but that is, again, just another tool that you can use to look at ASD in older children. And it's likely that kids who are a little bit older could have been missed for ASD. We're really focusing on screening and doing early diagnosis, but one thing that you may or may not know is that insurance coverage for autism is something that has happened recently in this state. And prior to that, a lot of kids, there wasn't a really big need for them to get a formal diagnosis. So they might have gotten services, maybe because they have a developmental disability, but not specifically identified as autism. So you could very well have kids who, although they've had autism their whole life since they were 3, they've had these symptoms, but maybe they kind of fell through the cracks with getting a diagnosis. And now, in order to get access to additional services, we need to give them a diagnosis for the first time, even though they're older. So it is important that we use those types of tools as well. Okay, so that slide talks about the things that I mentioned while we were looking at that. So now that we kind of went over that, what do you do with this information? And I think that the most important thing for everybody at this point to think about is, what kind of contact do you have with kids? At what age do you have contact with kids? And then how can you incorporate some of these things, some of these tools into your current practice? You know, maybe you don't have time to do an interview, but could you, maybe while the child is sitting and waiting for an appointment in your office, could you hand the parents an MChat? Could you hand them a screener so that they could at least go through that? Could you collect some of that information from them in a different way? who in your office or in your practice might be the person to do this. It's going to be different depending on your setting. Is it going to be you? Is it going to be maybe somebody else, maybe the office secretary, maybe somebody else that works with you? So it's really important to think about, how is this going to happen? The next thing to think about, and one of the barriers I think that parents come into contact with, is once they get a positive screen, how does that professional respond to them? Because I think it's really important for you to be able to give them that information in a very confident way. And it's okay to tell them that, yes, your child did have a positive screen, but we may need to take it to that next step. And it's very important that you get your child to the next step. There's sometimes a delay. Some parents are really comfortable. They knew that there was always something wrong with their child. Some parents are not. Some parents are not ready, and they need that little extra nudge to get them to the next step. And it's very important for you guys as professionals to be the person that gets them to the next step, because they're already in their office, which means that you already have a relationship with them. And if you have a relationship with them, they are more likely to trust you and follow your direction. So I think it's very important that this becomes something that you're really confident in, and you can kind of know enough about this so that you can get them to the next step. So if you're not comfortable with that, then all of the resources that are here, and there are lots of other things on the internet that you can look at to try to become more comfortable, so that way you can really give this information to families with conviction. So, as I said, you are sometimes the only person or the very first person that's had this conversation with people. So I think it's really important to guide them. One of the other things that we're going to talk about is the time delay between when people get a diagnosis, or when they get a referral, and then when they get a diagnosis. So they may have a positive screen, but it may take them up to 16 months before they actually get to the point where they get a diagnosis. That could potentially be speeded up. There are some roadblocks to that, because it may take some time before they can get appointments with the appropriate professionals, but sometimes the delay is in the parents not being sure or being afraid to take the next step. So I think it's really important that maybe you can also schedule a follow-up or do a follow-up phone call with people to check to make sure you got this information. Now, what did you do with it? And really helping them to educate them and understand what's out in their community. And those are the things that we're going to talk about next. So before we take our break, I'm going to go through what the diagnostic evaluation process looks like. And it's something that you need a lot of training in. It's not something that everybody is going to learn how to do, and probably most people in this room would not be responsible for doing diagnostics. But it is important for people who are doing early screening that they really understand the diagnostic process, because honestly, it can be very frustrating for families, and it can seem very cumbersome to kind of navigate through this. And as professionals, the more we know about these processes, the easier we can help the families really navigate. So getting a diagnosis for autism, it should happen in a multidisciplinary way. As I said, there are lots of different things that go into autism. It's a fairly complex disorder. Typically, what you're looking for is the child is going to see a neurologist. They're going to try to rule out any other neurological problems. Up to 25% of children with autism will also have some additional neurological issue, tics, seizures, those types of things. So it's very important that they also get looked at by a medical professional. There may be other people that you need to look at as well. Kids with autism have a lot of comorbid difficulties in the medical arena. They have gastrointestinal problems, they have sleeping problems, they have feeding problems. There's all kinds of things that could potentially be happening as well. So if they need to be referred to those services, it's very important that they get there as well. But at the bare minimum, if they see a neurologist, the neurologist is going to be able to do some physical exam with them, and they will be able to refer them on to those other places if necessary. The second prong is the psychological evaluation, and that's where most of the diagnostic testing that I'm going to talk about comes from. There are some real specific things that you're going to do. You're going to do what we call the ADOS, which is the Autism Diagnostic Observation Schedule. And there's some other autism-specific evaluation tools that we're also going to talk about. We're going to be screening for some of those medical issues or other kinds of things as well during your psychological evaluation. And then the third prong of this is the speech and language evaluation. And the diagnostic process is a little bit different depending on what mechanism you're trying to get people into for services. So right now, there are two main avenues to get service. Basically, it's public insurance and private insurance. So kids who have Medicaid may not have to go through all of these types of things. However, it is still recommended, particularly for some of those medical components that we make sure that we look into that. But in order to get access to treatment, they don't need the neurology and the speech and language. They do need the psychology to be able to do those specialized autism evaluations. Insurance companies, private insurance companies, each of them are going to handle things a little bit differently, but I put these three on here because Blue Cross Blue Shield has a very specific pathway to get into applied behavior analysis services, and you actually have to have all three of these in order to get a diagnosis, to get access to applied behavior analysis services. So they call it their multidisciplinary team. And there's actually a review process, and there's only, I believe right now in Michigan, 12 sites that can actually, they're authorized to do this type of an evaluation for Blue Cross Blue Shield. I'm going to show you a slide later on that has a website that you can look those up so that you guys can access that information as well. But in order to get access to applied behavior analysis, the neurologist, the psychologist, and the speech and language pathologist all have to agree that the child has autism. They all have to have a discussion about that child and then sign off on this. So one of the reasons I inform you guys about this is because that could take some time. All of these professionals are very busy, and it takes quite a bit of coordination to get them all in the same room together to have this discussion, and especially if we're trying to service all the children in the state who have Blue Cross Blue Shield in 12 sites. That can be cumbersome as well. So just to kind of think about what this process is, if there's anything that you can do on your end to help the families navigate that, whether it's having a relationship with the neurologist, having a relationship with one of the sites that actually do these evaluations, or following up, making phone calls, helping the families navigate the insurance company, all of those things are really important. So basically for the diagnostic process, we are looking at reviewing the history, reviewing medical evaluation, medical history. We're doing some sort of a developmental interview. So we need to speak with the parents. We need to get their perspective, what's been going on with this child. If they are a younger child, it's sometimes easier because they have to recall just what's current. If they're an older child, sometimes that can be a little bit more difficult because we're recalling information from when they were younger, because we have to make sure that those features of autism were apparent between the ages of 3 and 5. So that can sometimes be a challenge for older children. But we're doing some sort of parent interview. We're also doing direct observation, and we're going to talk specifically about the ADOS, but the ADOS is a direct observation tool where you have a child in a room and you're doing some very specific activities with them, which is different than a standardized test, and I'll explain that, but you have to actually be working with the child. It's also really important that we get some cognitive assessment as well as try to assess how the child is functioning adaptively in their environment and any other mental health scenarios that may complicate the issue to either rule out or rule in specific situations that may be comorbid. So our parent or guardian interview, what is recommended as the gold standard for this is called the Autism Diagnostic Interview Revised. This particular assessment tool is a semi-structured tool, and it is really keyed for the DSM-4, but you're still going to get accurate results with the new definition because, as I said, those things are just kind of combined at this point, so they still have all of the same features that you're looking for. In order to administer this, it is recommended that you have considerable amount of training for this, and one of the reasons is although it is semi-structured, there are some core questions that you're asking the families, but a lot of times how you ask those questions can determine how the parents answer. So if you have a bias going in that you feel that your child should get a diagnosis of autism, you may answer the questions in a very specific way if they're just written off the page, or if they're just read off the page for the parents, because as a clinician, you're looking for things, but you want to have a conversation with the parents to try to press them for very specific examples and things like that so that you don't bias it. And in the opposite direction, some parents go in and they really do not believe that their child has autism, and they don't report some of those kinds of things. So again, really kind of digging and looking for that information and then scoring it appropriately does take a little bit of training, and it's important that you have inter-rater reliability with other clinicians that are experienced not just in autism, but also in administering this particular tool. It takes between an hour and a half and 2 hours. There are 93 items. Not all of them are scored, so you don't have to actually administer all of them. But you do definitely need to get a good picture of all of the things that are going on. And again, there's that recollection for older kids of between the time that you're 3 and 5. And then you're looking to do this with a child who has at least the mental age of 2. So that is the parent interview. And very similarly to the other things that we've been talking about, it has specific questions for repetitive behaviors, communication deficits, social interaction deficits, and again, the age that those things may have manifested. So those are really important. This is really good as a tool because it gives you the opportunity to account for all of the child's life. So if they are older, you can look back. It's also very comprehensive. If you do an office visit, you're not going to get the whole scope of what's going on with the child, so this is really important. And then you also have the opportunity to use your clinical judgment in interpreting the parent report, which can be really helpful because sometimes, as I said, parents kind of come in with sometimes their own biases on how they would like the evaluation to go. However, it can be very time consuming, and it does require some training, and then it is solely a caregiver report, so you don't necessarily see the child in this situation, and that's important to consider as well. The direct observation tool is the Autism Diagnostic Observation Schedule. This can be used with kids actually at 18 months. There's a toddler version now, all the way up to adulthood. And this is the kit. It's a lot of stuff. And the reason why there's so many things is because you're basically setting up situations for the child to engage in a variety of play activities. And those are going to be very different depending on the age of the child. There are 5 different modules, obviously 1, 2, 3, 4, and 5. They go not just in order of age, but also in skill. So for example, the difference between module 2 and 3 is how much speech they have. So if a child is old enough to have a certain amount of speech, old enough to play with these types of toys, they also have to either have phrase speech for module 2, or they have to have more fluent speech in order to participate in module 3. So as I said, this is play-based. This is really so that you can observe social interactions, play, gestures, eye contact, all of those things that you saw in the social and communication ranges, as well as in the behavioral range. We're looking to not only have parent report from that, but we're also looking to see it for ourselves. Okay, so I think at this point we're going to go ahead and take a pause for a 15-minute break. So feel free to get up and get refreshments or use the restroom, and we will reconvene at 10:45. And we're going to get into the referral portion. So we're going to talk a little bit about applied behavior analysis and then about the parent perspective before we end our session today. So that's where I'm going to start. Actually, before I do that, we did have a question from Northern Michigan University. The question was, will Blue Cross Blue Shield accept a psychiatrist referral? So I think what this person was referring to is in replace of the neurologist on the Blue Cross Blue Shield multidisciplinary team, there can be a different medical professional. So a psychiatrist could be the medical professional, or sometimes an MD can take the place of a neurologist for that person. I do apologize for that. Our system, we do use a neurologist, but other systems, they do use other medical professionals. So a psychiatrist can sit in on that team as well. If that's not the question, because when you're talking about a referral, this is actually not a referral process. This is the process for Blue Cross Blue Shield is 2 steps. The first is the child has to receive a diagnosis, and this multidisciplinary team is set up for them to receive a diagnosis. Children with autism cannot get authorized for treatment in applied behavior analysis unless they have an authorized diagnosis through this multidisciplinary system. So anybody can refer a child to get a diagnosis, but the diagnosis itself is that controlled mechanism that I was talking about through Blue Cross Blue Shield, where you have to be what they call an AAEC, which is an approved autism center for evaluation. So that's really important that they do that, because if they don't, we can't start evaluation processes to get them started with applied behavior analysis, which we will talk about next. So hopefully that was the question that you were looking for. If not, go ahead and send it in again and maybe I can fix it. So anyways, applied behavior analysis is the gold standard treatment for autism. Basically what applied behavior analysis is it is an intervention that really assesses behaviors of the child on an individual basis, and it assesses how those behaviors are manifested in the environment. So we're working with each individual child and their actual behavior. We're observing it, we're measuring it, and then we're using our objective data from our observations to make data-based decisions on what that child needs to learn, how we need to change their behavior, how we motivate them to make changes. So we're going to talk a little bit about what that looks like. It's all based on learning theory, and basically we have this interactive circle between behavior, environment, and what's going on in our head. So the idea is we make modifications to the environment, which then motivates us as individuals to change our behavior. So I can't change your behavior specifically. I can't make you do anything that you don't want to do. But what I can do is I can change the environment, which then could motivate you to then make a change in your behavior. So if I turn the air conditioning on really, really low right now, if somebody's got a sweater over the back of their chair, that might motivate them to put their sweater on. It might motivate them to do a couple other things, like maybe get a cup of coffee or things like that. So I didn't make you do those things, but by changing something in the environment, I can then motivate you to make a behavior change. If that particular behavior is reinforced, you're more likely to do that behavior again in the future. If that behavior is not reinforced, or if it's punished in some way, you're going to be less likely to do that again in the future. So that's kind of the underlying premise of learning theory and what all of our treatments are based on when we're looking at applied behavior analysis. So we learn through two different ways, and most people are pretty familiar with the modeling way. People, kids, adults, they watch other people, they do what other people do, and then those behaviors are often rewarded. But there's also contingency learning. And this is something that we focus on a little bit more specifically with applied behavior analysis, because kids with autism are not modeling. One of the problems with kids with autism is they're not attending to their natural environment, and they're not imitating what other people are doing, so they're not getting exposed to the contingencies that everybody else is being exposed to. So we look at trial by trial learning, which basically means that that environmental contingency that I described through learning theory, we try to evaluate that and then we try to modify it. So I may make a change to the environment with a very specific motivation to try to encourage you to do a different behavior. I may reinforce a very specific behavior that I want to see again. So I'm manipulating that on a trial by trial basis to try to move that child in one direction or another. I'm either trying to increase their behavior because they have a lack of behaviors within all those skill deficit areas, so I'm trying to teach them new behaviors. Or, like in some of those behavior problem areas that I was talking about, I'm trying to reduce behavior. So I'm trying to change the contingency so that they are not motivated to engage in those particular behaviors. So this is a diagram that really just kind of highlights those two things. So we're looking to either reinforce behavior, or we're looking to punish it or extinguish it, which would be the other term. So reinforcement, most people are familiar with. I'm going to give you something that's going to encourage you to do something again. Or negative reinforcement is actually, I'm going to take something away, which is going to encourage you to do it again. So for example, a negative reinforcement contingency would be if I'm in the car with my daughter, who's 13, and she turns on a Justin Bieber song, I may be not very happy with that. So I may engage in a behavior that then gets her to turn that channel so that I don't have to listen to Justin Bieber. And if I do that in her presence and she changes that environment the way that I want her to by taking away that Justin Bieber song, that's going to reinforce my behavior. So I may go, hey, turn that off. And then if she turns it off, the next time I hear Justin Bieber on the radio with my 13-year-old, I may go, hey, turn that off. And that reinforced my behavior by taking away something I didn't like. So I can add something to the environment that I like, which will increase my behavior, or I can take something away from the environment that I don't like, which will also increase my behavior. Most people are familiar with punishment. Something bad happens when you engage in some certain behavior, you're less likely to do that again. So those are the two premises that we're working on with applied behavior analysis. There are lots of different strategies also within applied behavior analysis. So sometimes parents and professionals are confused, but some common things that we use in applied behavior analysis might be discrete trial teaching, incidental teaching, natural environment, verbal behavior. These are some slang words. PECS, that's something that people may have been familiar with. PECS is a picture exchange communication system. It's used for kids that are nonverbal. Other things that you might see in a classroom, timeout, for example, or sticker charts, or those kinds of things. Those are also based on applied behavior analysis. So anything that we're going to do, anything that we're going to do that's going to systematically manipulate something in the environment that's going to have a motivational change towards behavior is going to be based on applied behavior analysis. And it's going to be very, very different for each individual who's targeted for treatment, because we do a lot of assessment and we take ongoing data for progress monitoring, and then we're really looking at that to develop how are we going to make this change. So we use applied behavior analysis to positively impact a lot of different things. We're trying to change our nonverbal behavior. We're trying to increase just in general cognitive functioning like IQ. We're trying to increase language both receptively and expressively. We're trying to increase just general knowledge skills, communication, daily living skills. We're trying to increase social skills. We're trying to increase motor skills. Pretty much anything that you can do, we can increase. So if you have a deficit in a certain area, we're looking to try to increase those things so that you're performing at more of a typical development level. So we're looking at comparing you to your peers and then trying to say, where can we fill in the holes? And we just start building skills. We're also trying to, as I said, reduce some problem behaviors. So some things that we might be targeting are the obvious ones like tantrums and crying and those kinds of things that are often associated with kids with autism, as well as other kids who don't have very good communication skills. We're also looking to reduce things like self-injurious behavior or self-stimulatory behavior, non-compliance, kids that elope, run away. We can also reduce some other things that people don't always think about. So we can reduce anxiety. We can reduce like oral mouthing. We can reduce arguing. We can reduce hyperactivity. We can reduce anything that you can do. So again, anything that's a behavior, by changing the environment and by teaching some skills or, focusing on decreasing certain things, we can start to modify some of these. So these are just some of the things that we might work on in applied behavior analysis. Pretty much anybody can benefit from applied behavior analysis because, again, it's just skill building and behavior reduction. So we use applied behavior analysis for kids with autism because it's a funded source. We have permission to get paid to do work with kids with autism using applied behavior analysis, but pretty much any kid of any age is going to benefit if you systematically look at the environment and make some modifications to promote learning. So all of the kids that come to our center, whether they're 2 or whether they're 20, we can definitely make changes with them. If they have really moderate deficits versus really significant deficits, we can also make changes with them. So some of our kids are going to be really high functioning, some of them are going to be really low functioning, some are going to have really aggressive behaviors, some are not going to have any problem behaviors. So really, again, this is a very individualized type of intervention. The key thing that we're looking for is parent motivation. We want the parents to work with us as a team member. We want them to be really participating with treatment. We want them to be engaged because in order for this to work, it's not only us that has to promote changes within the environment, but they have to have changes in the environment across all environments. So in the home, in the school, and other places that the children go. So the parents really are often targeted as needing to develop skills as well. All parents come with different skill levels, which I'm sure everybody in this room knows, but when you have a child with a disability, sometimes you have to learn a different skill set. And we really focus on what does your child need within the skill deficits that they have that you need to do differently, and then how can we promote that within you so that you're having more success in your own environment. Treatment is really different depending on what your goals are. There are a lot of research articles that support the idea that about 50% of kids who enter treatment and get a very intensive behavioral intervention program at an early age could come out of that within 3 to 5 years as not needing additional services. So not that we're curing autism, but we're teaching enough skills so that they become just like their typical peers in the areas of social skills, communication, and behavior. So if we can catch them early, we're looking at reducing special education services, we're looking at reducing community mental health services, we're looking at reducing medical bills, and all of those other kinds of things. There's also some new data that shows that if we get kids when they're 2, they don't need that much therapy. They need 1 to 2 years of therapy. If we get kids that are 3 to 5, they need a lot more therapy. So catching them earlier means that they have a lot less skill deficits, and that means we have a lot less work to do. So it's really, really important that if we can catch these kids early, not only does it change their developmental trajectory, it changes how they're going to live, how productive they're going to be, how they're going to work in their schools, how they're going to work as adults. So again, that cost reduction piece that we were talking about at the beginning. So when you're thinking about applied behavior analysis, what makes applied behavior analysis different than other approaches is it's functional. And what I mean by functional is it's not just related to skill deficit. It's related to motivation. So I'm going to teach you something, but I'm also going to motivate you to do it. So we're really looking at what we call function-based treatment or functional communication training, those types of things. So we want to teach people to do things that are going to get their needs met in their own environment. So if I have a child who's not speaking, I'm not going to teach them their alphabet. I'm going to teach them something that's going to be really functional that they're going to directly use in their environment today, right now. So it's really important to think about that. The other thing that makes ABA really different from other things is the high amount of structure. So we're really programming for everything, and we're really giving lots and lots of learning opportunities, which is different than a classroom. Again, we're looking very specifically at that child, and we're making sure that every single time that we ask a child to do something, we're looking at that consequence. Was it reinforcing for them to do that? Were they motivated to do that? Are they going to do it again in the future? So those are some of the things that makes it a little bit different. Focusing on high family involvement, focusing on strategies for generalization, focusing on transitions, making sure that we're collaborating with all of these different environments, and again, that small ratio. I didn't mention this yet, but ABA is typically done in a one-on-one setting. So the services that we're looking at, one of the reasons why they are so costly is because we have one behavioral technician that works with one child for 20, 30, sometimes 40 hours a week. And that's a lot of time, but when you think about the gains that you can get in that short period of time, we're really trying to increase the number of learning opportunities that that child has so that they can overcome some of their skill deficits. If you're looking for a tool that gives you some information, oh, I'm sorry, go ahead.
That's okay. The question would be, for me, is there any evidence to show that children that did not have the early intervention when they were younger, that have a diagnosis of autism, don't get started or have any type of therapy later in life, like 16, 17, 18, is there any studies or research that's done with those folks using this therapy and any positive results? Like, there was no diagnostics done when they were young, they knew something was wrong, but they didn't have this intervention at that young age.
Right. So the question is whether or not there's any research or literature that shows positive impact for children receiving applied behavior analysis at an older age, so not at that preschool age. And actually, there is literature going back 50 or 60 years that talks about different behavioral strategies used to increase people across all kinds of diagnoses. If you look in the applied behavior analysis literature, most of these things are single subject design. So what's missing is there's not a large group design to show exactly what the overall benefits would be, but there are hundreds and thousands of single subject or small group designs with kids of all kinds of ages. Now what happens with older kids is they have a lot further to go. So you're not going to get to the point where they're not going to need services. They're going to need services, but how much they're going to need and what problems they enter with, those things are going to be determined by how much intervention they get. They're going to be determined by what kind of behavior problems they had. So a child who comes in with high rates of self-injurious behavior and aggression, not going to make the same kind of progress. Our goal would be, let's reduce those behaviors. Let's get them, functioning out in the community. Let's get them learning how to shower themselves. Let's get them learning how to, make their own lunch. Those kinds of things we might be working on. Still very significant things that you're improving the quality of life of a young adult with somebody with autism, or an adolescent of somebody with autism. So these things are going to be effective. There are, I would say, I'm not familiar with anything that just does an intensive behavioral intervention with a group of kids that are significantly older. I think there are 1 or 2 studies that compare the outcomes of younger children to older kids, but they're not. They're like 6 or 7 years old. They're not much older, if that makes sense. But what we know with applied behavior analysis is it works across a lot of different diagnoses, behavior problems. Pretty much you're just changing behavior, and a behavior is a behavior is a behavior. Okay, so ASAT Online, which you can Google, is a resource that if you want to look up different treatments for kids with autism, they actually have a whole laundry list, like hundreds of different things, and then you can click on those things, and then it will tell you what the research is behind it. So it's a really cool resource, because if you're looking for evidence-based treatment and you're looking to see, is this going to work? Is this going to be harmful? Is this going to be really good? It's a nice resource for parents and professionals. So now we're going to talk a little bit about what you might find in an autism center. So there are different types of centers. You might have a center-based program. You might have a home-based program. But, excuse me, when a child enters applied behavior analysis treatment, we have to do an additional assessment. So we have a diagnostic assessment, and that tells us, yes, the child has autism. But now we need to do a functional behavioral assessment. We have to not only figure out that they have autism, but what exactly are all these skill deficits, and what's motivating them to engage in this behavior instead of that. So there's another step in the process, unfortunately, for parents, but it's a necessary step so that we can put a plan together that's going to be effective. Different programs are going to take different kids. Taking older kids is a newer phenomenon in our state. It's not something that people have been doing for a very long time. So not everybody has experience. Many people have just been trained in preschool interventions. So you may find programs that won't take children that are older. But you definitely want to ask, and you want to look into those kinds of things. Different programs are going to be able to handle different levels of behavior as well. Some programs, they're not going to have staff that are going to be completely prepared to deal with really aggressive or severe types of behavior. So you might want to also look into what is the training, the qualifications, those kinds of things at each individual center. But for example, at the center that I work at, we have different age groups. We have young kids, like preschool age kids. We have elementary school age kids. We have middle school age kids. We have high school kids. And we have different things that we do with them, different kinds of programs. For our middle school program, we have like an after school kind of thing, so the kids come for less hours, but we also, again, look at each individual. So sometimes our kids will actually come to our center instead of going to school, depending on their level of severity. If they have very severe behavior problems and they're not functioning very well in that setting, they may come to our center for a period of time instead of going to school. So we may have a 7-year-old or an 8-year-old who has 30 or 40 hours of intervention a week. And then once we kind of get some behaviors under control, once we get them attending to the right stimuli in their environment, we push them back into the school, and then they do much better. One of the other things you want to look for at Autism Center is what kind of parent services do they have? Do they meet with the parents regularly? Do they have any parent groups? Do they have parent education? Those are things that are really important. You want to, again, look at the age. Look and see, do they have any kind of transitioning programs? If you're looking at somebody who's like 18-ish, you know, where are they going to go next? Are you going to do this procedure with them and then they're just going to go back into the world the way that they were, because that may not maintain? So those would be good questions to ask. The people who provide services at an Applied Behavior Analysis Center would be at the top a BCBA. A BCBA is somebody who's a master's level clinician, and they would develop treatment plans and they would train staff and parents. sorry, I'm going to go back for just a second. Underneath of them, this is really a train the trainer model. So underneath of them, there are several levels of professionals. The person who works directly with a child is typically called a registered behavioral technician, or sometimes just a behavioral technician. A registered behavioral technician is going to have a little bit more training and education, and they have a specific certificate. They are the person that's going to put in the bulk of the hours. They're the person that's going to do 20 hours a week or 30 hours a week or 40 hours a week with this kid, but they have less training. And because this is a train the trainer model, the person with the most training is at the top of the pyramid. That's the BCBA. And then they have to monitor all these people below. So there's actually a middle person. In our state, there's not a lot of them. Our state is really pushing to develop these people, but that is a person who has an undergraduate degree, and they would have a certificate called a BCABA. So that is a behavior analyst assistant, basically. So you have your behavior analyst who's running the show, then you have your assistant, and then you have your technician. The role of the assistant is to help with additional training and to support the BCBA. Currently, if you're looking at a caseload for a BCBA, you're looking at maybe 10, maybe 15 cases because it's very intensive. You're looking at a lot of hours, and there's a ratio of supervision of 10%. So if you have a 20-hour-a-week program where you have a behavioral technician working with a kid for 20 hours a week, we're going to expect that the BCBA is going to be involved in that case for 2 hours a week, because they need to meet with the parents, they need to train the staff, they need to supervise, they need to be looking at progress data. So the more hours each child has, the more hours of supervision you can expect. So with that kind of supervision, you're looking at a small caseload. If you have a BCABA in the middle, they can help to extend the BCBA's caseload. So they can do some of those supervision times, they can do some of the training, so then the BCBA doesn't have to be so involved with the case, and maybe they go out once a week instead of twice a week or something like that. So that's kind of the train the trainer model, and those are the things that you can expect. One of the things that we also recommend for applied behavior analysis right now is some sort of a review of cases. So many times behavior analysts are out working in the community kind of independently. One of the things that has happened in our community recently is behavior analysts are very new. This is a new job, this is a new profession for our state because the funding source just started a couple of years ago. So we have gone from less than 100 BCBAs in the state to over 400 BCBAs in the state in 2 years. So it's really important that those new professionals out in the community are getting support from other people who are either more experienced or other medical professionals. Again, this is a very complex diagnosis, so we want to make sure that cases are being reviewed. This is something that some of the centers are starting to do. I think it's a really good idea. Again, that multidisciplinary approach. If we are going to have applied behavior analysis, we really need to focus on what other professionals need to be involved and what kind of coordination of care do we need. So if you have a child that you are working with that you referred for evaluation and then they are now in an applied behavior analysis program, I highly recommend that you try to communicate with that professional. Again, a lot of these people are new, they're kind of overwhelmed, they're probably taking more cases than they should. So reach out, contact those people, try to coordinate, because what they're asking the families to do may be very different than what other professionals have asked them to do in the past. Or what you're doing may really impact what that child's going to do in treatment. So the coordination of care is really a necessary step in this, especially if we want behaviors to cross over from the treatment setting to the other settings in the community. So that's very important. This is the website that you guys can go to for the Autism Approved Evaluation Centers, so I'm not going to go over that because we talked about it already. So one of the reasons why I give you all this information is because you are the people out there working with the families. You are the people out there who are obviously interested in providing care for people with autism. And this is, again, a very new service. Parents don't know how to navigate it. They don't know what's good, what's bad. So by me telling you what the gist is for what you can expect for services, you now have some information about how to help navigate the parents through. You know, is your program doing this? Are they offering this? Oh, they don't have people that have worked with older kids. Maybe you need to look for another agency. Maybe that person needs to get support. Here are some other places. So I think it's really important because it's so new, nobody can really tell, is it good or bad? Is it working? Is it not working? Because people out in the world don't really know what to expect as of right now. So hopefully you can take this information, you can educate yourselves, you can educate the people that you're working with, and you can educate the parents who are trying to access these services services so that they're getting good quality services as well. One of the things that we have to do quite a bit when we're working with insurance companies is a lot of coordination of care. And this kind of goes back to making sure that we're really focused on communicating with each other. For example, Blue Cross Blue Shield has mandates for us within the treatment plan that they want to know who we talk to. They want to know how frequently we talk to the speech and language therapist. They want to know how frequently we talk to the school. They want us to document that because they want that crossover. They want that generalization. So it's important for everybody out in the community to really help to promote that. It's also important to recognize things like goals, hours, certain standards, criteria. A lot of those things are also highly reviewed by the insurance companies, and they're looking at these treatment plans very strictly. So it's important to kind of realize that sometimes when we ask for kids to be either removed from this or pulled out from this or something like that, the insurance company actually has to approve that. So it has to be medically necessary for that child, or the insurance company isn't going to authorize it. These are some resources that you can look into. I'm not going to go through each of them because one, we don't have time, but you guys all have access to the internet. But in particular, the Autism Alliance of Michigan, which is number 3 on the list, they have a navigator system. So if you go to their website and you're looking for services, that's a really good one. You can find speech and language, you can find ABA, you can find pediatricians, you can find a lot of things, and they sort it by county. So you can do it by location, which is really nice. There's another slide. Is it this one? Nope. This one. This particular, no, not that one. This one. I'm going to open this one up. I want you guys to see this. If you're trying to navigate for Medicaid families, you want to find services for them. That's a little bit different. So let me show you that really quickly. So you would get, if you clicked on that link that I showed you, you're going to end up here. And this is super cool because when you go through here, you can go, okay, here's my county. We're in Ionia County, is that right? Kent County? Okay, we're in Kent County. We're going to go to Kent County, and then it should. Do you have services in Kent County? Let's go to Ionia County. Okay, maybe there's no services in Kent County. Okay, so if we're in Ionia County and we click on Ionia County, we can go through and say, all right, these are the PIHPs within that region. This is the person that I call if I want to get access to applied behavior analysis services. If I want to get a diagnosis for this particular child, this is how I get into the system. So it's super cool. It makes it really easy that they just go into whatever the county that they have, and then these people will help to navigate. Most of these places don't have people that work directly for community mental health. Most of these places are contracting with other applied behavior analysis providers, and they're doing it that way. Sometimes an applied behavior analysis provider is covering like several regions, so that may be happening as well. There are some waiting lists, but this is a good tool if parents are looking for that. There's other stuff on there if you guys want to know about autism legislation, if you want to know about all that kind of stuff, that is also there. Okay. Just to go back for a minute, this is just general medical information for the most part on autism. If you go to these websites, some of the stuff that I talked about early on about prevalence rates and things like that, if that's of interest, those might be better resources for you in that area. Okay, so we're going to spend the last few minutes talking about parent perspective. This is really important because the parents are the people that are going to get the children into services. So I don't know if anybody's ever had an experience where, let's say they go to the doctor and they get some sort of a recommendation from their doctor. Their doctor says, you should take this medication, or you should take that medication, or you should follow up and get this evaluation, and you don't do it, right? There's a lot of people, probably everybody in the room has probably had at least one incident where they have been told by a medical professional that they should do X, Y, and Z, and then they've just decided maybe it's not the right time for them to do that or whatnot. So this is the same kind of thing. And if we had other people supporting us and saying, hey, it's really important that you do that, or this is a really big deal, or this can't wait, we might be more likely to follow through with that treatment and adhere to whatever it was that the doctor recommended. So these are the kinds of things that I want you to think about when you're thinking about the parent perspective. So we're going to start off by talking just a little bit about a study that really assessed the parents' the parents' perception of how they have engaged other treatment providers. So in this study by McIntosh and his colleagues, they looked at 486 parents, and more than 70% of them said that they were dealing with increased levels of stress. So that's an important thing to think about. So you have a child with a disability, obviously that's going to increase stress. Your child's not talking to you, they're not playing with you, they have all these odd behaviors. So you're going to feel stressed out. Think about the little girl that was lining up the cups. If that was every day in your house, you would be a little bit stressed out. So we have an increased level of stress. When you have an increased level of stress, other things tend to fall by the wayside. Your own personal self-care, how often you're going to go to the doctors, what's going on in your life, some of those kinds of things. One of the other things they assessed is the relationship that parents have with the professionals that they're engaged with. And they said that 73% of parents reported negative relationships with service providers, including consultants, behavioral technicians, psychologists, and pediatricians. So they're going to access services where they're trying to reduce their stress, and they're trying to get, better services for their kids, but they're not having good relationships. They're not trusting those people. They're not communicating very well with those people. They're not feeling like they're getting their needs met. So when we're thinking about that, and we're thinking about access to treatment, and we're thinking about follow-through, and we're kind of thinking about what the parent's perspective is, it's really important that us as professionals are very supportive in nature, but we're also really focused on making sure that the parents are actually getting their needs met. Because if the parents aren't getting their needs met, they're not going to be very motivated to implement the treatments that you're asking or even show up to the appointments that you're asking them to. So that's a very important thing to be considering. Just a little quick excerpt. I'm just going to read this. The responses from our participants suggest that the process of accessing desired treatments, managing the costs of money and effort, and dealing with a wide array of ever-changing professionals disrupt the equilibrium to the entire family. So this is hard to navigate. One, it's new, so it's hard for us to implement it because we're navigating a new system, but then it's hard for them because we're constantly changing things. We're having a difficult time because our caseloads are too high and all of those kinds of things. And it really makes it difficult for the parents. Another thing that I didn't mention when dealing with insurance, it's great that this has been picked up by insurance, but if you have private insurance, you still have copays. And there's a copay for every day that you show up to treatment. If you show up to treatment every day, so 5 days a week, which is typical for our kids, and you have a $20 copay, now you have a $100 a week fee on top of what you were already doing, even though it's not going to cost you $50,000 a year, which is what it would cost you without insurance. It's still going to cost you an extra $500 a month, which maybe you don't have. Or maybe you have to give something else up because now you have to pay for that. So that's something to think about as well. The diagnostic process is very difficult. As I said, you have to sometimes wait up to 16 months. By the time you get that referral or that MChat where you're like, you need to go and get a diagnosis, then you've got to go and there's a waiting list. There's also typically 3 appointments just for the psychological diagnosis. You do the parent interview, you do the ADOS, then you have a feedback. Then you have to see the neurologist, which who knows how difficult it is to get into them. And then you have the speech and language evaluation, and then you have to wait until the 3 of them get together. So there's all kinds of roadblocks. The reason I say this is because it might help just to let the parents know. This is what you might expect. Because if you know something, it's easier to deal with. It reduces your stress. It might also be helpful for you to be a supportive person and kind of follow up on that process. Where are you? Oh, your kid was sick. Did you reschedule that appointment? Those kinds of things can be very helpful. The diagnostic process itself is just unclear, and it's one of the things that parents report as very problematic, and it often results in people not showing up to their appointments. We have a tremendous cancellation rate. For as big of a waiting list as we still have probably one person a week that cancels. and then we have an open spot. And a lot of that is because we didn't coordinate care as well as we could have. So overcoming some of these barriers to treatment really has a lot to do with parent motivation. So we want to reduce parent stress when possible. We also want to educate parents on some of the things that I talked to you about applied behavior analysis, because we're asking them to devote a huge portion of their life to this treatment. We're asking them to give up something for several years potentially and take their kid to some treatment facility for a long period of time every single day. They have to really believe that's going to make a difference for them, because it's really hard to do something for a long time like that if you don't see the benefit for that. So it's important that we all work together to make sure that parents really understand what the outcomes are. And the more you guys know, the more you can help them understand, and the more likely they are to stay in treatment. So other things like inconsistent discipline, lack of structure, families feeling isolated, and parents just not feeling very efficacious about their ability to parent their own child, those are things that also decrease motivation. Those are the things that we focus on in applied behavior analysis. So if they get into treatment, that's going to be very helpful. And you might start to direct people into those things like, hey, make sure that you ask your therapist about that. Or have you thought about increasing what you're doing at home based on applied behavior analysis so that we can help with structure or parenting or discipline? Parent involvement is probably one of the most important pieces, because we can work with kids all day long, but not having them engaged in therapy is really problematic, because it really increases the cost, because we have to do a lot more work to coordinate with everybody else. It decreases generalization of skills. We may teach something to a child that never shows up in the community because we haven't gotten that involvement. And also, if parents learn this stuff, they become lifelong advocates for their own child, and they become educated in a way so that they can promote continued learning even after they're out of treatment. So why do we talk about this? How can you help? One of the things that we really need to think about is, excuse me, from the aspect of treatment for the parents, what can we do for them to support them and get them over this hump? And really, I'm going to go through some specific things. We have educational goals for our parents. We have things that we want them to learn as well, and I mentioned that in the beginning. But we really want them to first and foremost understand their child's disability. As I said, it looks very different across different children. So they may not have a good picture of how does ASD impact my child. So we want them to have a really good understanding of that. We want them to understand the trajectory of the diagnosis. We want them to understand how it could affect them in their school, in their community, in all of those places. We also want them to really understand the treatment that they've been engaged with. Again, because it helps to promote the better generalization, better skill acquisition. So we really want them to understand that piece as well. One of the key pieces to making this all work is our communication. And because the parents are one of the treatment team members, sometimes they're coming with different skill sets, like I said, too. And sometimes they don't have very strong communication skills, or they're not very persistent, or they have other things that are stressing them out that are making them not have the skills to be able to effectively communicate. So a lot of what we do is also educate our parents on how do you do these things. What do you need to take to this professional? How do you ask this professional this? When you go into your IEP meeting, what is that going to look like? Are you going to argue with them? Are you going to, bring in some cookies and have a nice conversation? What does some of that stuff look like to promote more effective collaboration and communication? What if mom is doing something that dad isn't doing? How is that going to impact the child and their treatment? That's going to be a problem as well. So sometimes we're working with making sure that the parents are effectively communicating amongst themselves. And then one of the other big barriers is parents feeling isolated, parents not knowing how to connect with their community. It's hard to go to the grocery store. You can't go to the movies. Everybody's looking at you. People come up to you and they're like, I can't believe you let your child behave that way. Well, they don't know what to say. They don't know how to deal with those kinds of things. So getting them connected to things in the community that are going to help them better parent their children is another way to be supportive and empower them. So whether it's what's the noise-sensitive movie that's going to be playing in the community this week, what's the parent support group, Is there a gymnastics place that has a developmental disabilities gymnastics class? What's going on in your community that you can connect them to? This is going to help them understand what they need to do, and it's also going to help them really manage what's going on. If they still are having high levels of stress, sometimes we're working with them to just understand how to better cope. We might teach them coping skills. We might teach them stress and relaxation skills. We might do some of those kinds of things. And this all helps to make sure that our treatment is going to be sustainable over time, because we don't want to invest this much time and effort and money into something like this if it's not going to actually have the effects that we're looking for. So just in general, our goal is to reduce parent stress, increase communication, and really empower them, because if they're more empowered, we're going to be able to have them help us with coordination of care. They're going to be the managers of their own children instead of relying on everybody else. And then to really understand the treatments that they're getting into. So what I hope that you guys got from today, and I'll take questions if you guys have any after we're done here, but I'm hoping that you have a better understanding of what autism spectrum disorder is. I'm hoping that you have in your head a way that you can implement screening into your clinical practice. How would you identify a child and how would you get them to where they need to go? Hopefully you have a better idea now of what that evaluation process looks like so that you can help guide and support parents to get through that difficult process. And then at this point, you should know a little bit more about what they should expect from applied behavior analysis treatment and what that might look like so that you can encourage parents to enroll in that treatment and then stay in that treatment so that they can receive the benefits and the effects of that. And then also what to expect from different autism centers and some of the challenges that parents face as they're going through the motions of learning how to be a parent of a child with autism, because no matter how old that child is, they may be at different levels of understanding the diagnosis just because of where we've been in this state with getting new services. Even if they have a child who's 15, they still may be at a different place. You still may need to go through what does this diagnosis look like. So those things I think are really important, and I hope that you guys all got some information that's useful to you that you can use in your clinical practice. So thank you very much. So does anybody in the audience have any questions here? Okay, I do have a question. This is from Wayne State University, and they ask, can you discuss medical necessity criteria and how that impacts how intense the ABA intervention is? And that is a really good question because that is a very elusive term. We're all required to demonstrate that a child has medical necessity, but the definition for that term is kind of up to interpretation. One of the things that we kind of go by is any child who is not functioning very well in their community, in their educational facility, in their family home, those kids would have medical necessity for treatment. Kids who are more significantly impaired and are having a really hard time learning from their natural environment are going to need more hours. So how delayed they are could dictate how many service hours they need. Also, how many behavior problems that they have could also dictate that. So again, for each child it's very different. But sometimes we have to use our progress data to also show medical necessity, and we work pretty closely with the insurance companies so that way we can talk about, you know, what does that look like in this child? I don't have a really hardcore answer for what exactly that means because there really isn't anything out there that says this is medical necessity. But if you have a child with autism and they have skill deficits, and they're not doing well in their environment, then they have medical necessity to receive treatment because we know how to fix those behaviors. So we should do that. Any other questions that anybody has? Okay. Well, thank you very much for your attention, and I appreciate you all coming out.